Good evening, everyone. I'm here to present the differences between TASS and endophthalmitis. Toxic anterior segment syndrome, also known as acute sterile inflammatory reaction or acute sterile anterior segment inflammation or sterile postoperative endophthalmitis. As we all know, endophthalmitis is inflammation of the inner coats of the eye with intraocular colonization of the infectious agents with exudation within the intraocular fluids. Both of these are bewildering entities, and at day one after surgery, it is very difficult to distinguish between them. But it is very important due to seriousness of the conditions and the divergent treatment strategies. TASS occurs due to toxic substance reactions occurring after any anterior segment surgeries, due to residues left behind by the items used during cleaning, sterilizations, or due to irrigating solutions with incorrect pH, osmolarity, due to stabilizing agents, denatured OVDs, endotoxins, heavy metals, or any other substance going inside the eye. Endophthalmitis can be due to preoperative, intraoperative, and postoperative causes. We have major outbreaks of TASS which have been reported throughout the worldwide. And various reported causes of TASS includes solutions, IOLs, ocular viscoelastic materials, BSS, antibiotics, anesthetics, intraocular dyes, and so on. TASS usually presents in 12 to 24 hours, and endophthalmitis in most of the cases do not show up until later. Still, there are reports of staph epidermidis and bacillus cereus endophthalmitis, which have TASS-like early presentations. Symptoms are usually rarely present or mildly present. There is little pain and significant inflammation in TASS, but in endophthalmitis, it is usually severe and pain is seen in more than 75% of the cases. In TASS, vision is blurred within 12 to 24 hours after the surgery, and in endophthalmitis, visual loss can be profound. The ocular motility is full and painless in TASS, and in endophthalmitis, the patient usually present with reduced or absent ocular movements in case of, along with proptosis and pain, and which can clinically point to diagnosis of panophthalmitis. In TASS, there is little conjunctival or scleral injection present. Furthermore, lid swelling is usually uncommon, but in endoph, there is conjunctival or lid injections and swelling as well. The corneal edema in TASS is variable and widespread, and we have a diffuse limbus to limbus corneal edema, which is hallmark of TASS, and it could be permanent. In endophthalmitis, the corneal edema is more localized and patchy and tends to improve with inflammation resolution. Pupil is usually fixed and dilated. Often there are spotty, diffuse areas of iris atrophy. And in endophthalmitis, poor pupillary reaction due to increased levels of bacterial toxins and prostaglandins, as well as uveal congestion. There is mild to severe reaction with cells, flare, and hypopyon, fibrin reaction on iris and anterior surface of the IOL in TASS, and the exudates are usually white in color. But in endoph, marked inflammatory response in anterior chamber with hypopyon is present. TASS present with elevated IOP, generally between 40 to 60 millimeter of mercury, and can have decreased IOP during early postoperative course, but progresses to permanent trabecular meshwork damage leading to secondary glaucoma. In endophthalmitis, intraocular pressure is usually variable. Frontal glow is okay or mildly poor in TASS, and in endophthalmitis, it is poor or absent. In TASS, there is no vitreous involvement. It can be clear, but spillover is possible. Vitritis is rare. Fibrinoid response is only present in the anterior chamber, and there is no retinal involvement. In endophthalmitis, there is marked vitreous involvement. There is inflammation of entire vitreous. There is retinal vasculitis, and mild peripheral retinal hemorrhages can be found. On ultrasound B scan, vitreous cavity is usually clear in TASS. In endophthalmitis, there is mild to moderate intensity points echoes in vitreous cavity. There can be retinochoroidal thickening. We can find IOLs posteriorly dislocated in some cases. There can be concomitant retinal detachment, choroidal detachment as well. So whenever we are in doubt or there is worsening of the inflammation on steroids, or if we find some atypical features, we should go for vitreous gram staining and culture, which is usually negative in TASS. And we can find positive cultures in endophthalmitis, usually gram-positive bacteria And 85.1% of all isolates can be due to gram-positive bacteria, 10.3 can be due to gram-negative bacteria, and 4.6% of all cases can be due to fungus. We have seen dramatic response with intense topical steroids, usually within 3-day course of steroid given every 1 hour. In TASS, in endophthalmitis, the patients usually respond to antibiotics only. The visual outcome is good. The patient usually has 612 to 6.9 visual acuity. And in endophthalmitis, we can have worse results. Significant predictors of poor visual outcomes include initial visual acuity of light perception or worse, and infection by virulent organisms. Coming to treatment, topical steroids are the mainstay treatment for TASS, which can be given 1 to 2 hourly initially and then can be tapered. Steroids can be given in the form of gels, emulsions, ointments. We can also give topical NSAIDs. IOP management is very important. And in refractory cases, we have to give intracameral injection of recombinant tissue plasminogen, which leads to complete clearance of the fibrin reaction. We can also go for irrigation of anterior chamber, vitrectomy, and removal of IOL. And in cases of endothelial decompensation or permanent corneal edema, we have to go for surgical treatment. In endophthalmitis, systemic antibiotics, local antibiotics, topical subconjunctival, intravitreal injections, and vitrectomy are the options with us. So TASS is a multifactorial etiology. It can be difficult to prevent. Once it occurs, TASS can be fatal to the cornea and the eye. But it can be prevented. It is best to prevent the syndrome using all possible precautions. So whenever we are in doubt, it is always better to err on the side of infection. We should treat empirically as well infectious endophthalmitis via vitreous trap and intravitreal antibiotics. Because we are unable to reliably differentiate it from TASS until a therapeutic response to topical steroid is clearly present for several days, endophthalmitis should always be the consideration. Thank you.